The second one, fluid resuscitation. Another one I see a lot. Oh, just start an IV and give them fluid. It's not that easy. Yes, an IV is pretty, like, I mean, it's a technique that you can teach about monkeys, but in emergency, we have people that after been doing that for 12 years, and there's still people that sometimes we cannot find IV. Sometimes it takes like 10, 20 times to try to almost get an intravenous in those people. So it's not that easy on some people. Yes, you know, if you have an 18-year-old with big nice veins and stuff to start your IV, yeah, but when you started, even like when I started emergency, I used to blow my IVs like all the time, because you know it's a technique, it's how you do stuff and everything. And a lot of people, they rely now their plan on starting intravenous. Well, if you have someone that is dehydrated in shock and that needs intravenous, first of all, their veins won't be as nice as they are on a nice person. So if you never really practice your intravenous, in the middle of a stress situation with very limited resource and somebody that is dehydrated, you'll be able to hit the vein on the first shot. If maybe you'll be lucky, but it's very unlikely that that's going to happen in the nice condition like this. So even to just even start the intravenous doesn't mean that it's a hard technique to learn. No, but it's not so much the technique as the why and the reason and how you start it. And then after that, what do you give to this person? So okay, you give intravenous, so that means you need to keep the bags inside. Well, the bag themselves are very sensitive. You have to keep them in a certain environment. Even when we have them in the chopper sometimes, like it's like minus 30, minus 35 outside, and their bags freeze, like they're cold, and even a lot of time they lose their, if they get too hot or too cold, they can lose their sterility, and their we cannot use them anymore because they lost their content of how it works. So they have to be stored in a proper way. And you have a expiration date as well that you need to use them for this. Then it brings us the question of like, what do you use? Well, if you look at the literature, medical field, and then I'll put a link on one thing that it's quite interesting that they did in Africa that I just read recently. And intravenous, you know, people were like, oh, just give it. And what arm, like I even read sometime, like what arm is there to give like 2 liters of saline? Well, there can be some arm, because there is different solution for different purpose for different things. And if you don't use the proper solution for the proper patient, it's not as easy as just say just give some fluid and that's it. There is different ways, there's different solution, and you need to give the proper solution for the same thing. So so right there already, and plus to keep again the supply, 2 liters, like just 1 liter of fluid. If you ever have a chance to hold one in your, it's heavy. It's 1 bag, well, it's 1 liter of water, so it's pretty heavy. So now if you need to keep like 10, 20 of those, that's a lot of heavy stuff that you need to carry. So I'll put a link for another, and there's another video that's going to come, and it's called basically intrarectal fluid administration, which would be probably a little bit safer to do and stuff. And I'll do a video a little bit more on stuff, but I'll put a link on one of the articles that I read, and there is some literature and stuff, and also PO administration. So if you want to be more my system depends more on that kind of administration, like drinking and maybe rectal if I have to, than having to start intravenous. Despite that, I know how to start intravenous, and I start intravenous all the time, but just even to keep the supplies, to keep all the stuff, and to keep everything that you need, it's almost impossible. So I would rely more on intrarectal and PO administration, or intranasal, like through not intranasal, but through an NG or a nasogastric. So basically a tube that goes through your nose, that goes all the way to your stomach or through your mouth, if you tolerate that one, and would be much better. And that will be part of the article that I'll put down the link there that they did in in Africa. And actually, it shows that it was almost better for pediatric that way than the others. So I would rely more on this, and it's much easier in a situation of low resource to have that kind of stuff than to start carrying your own intravenous and making your own intravenous, because some people, that's what they do. They were talking about sterilizing bottles and everything, and sure, you can try, but then you increase your risk of infection, which will probably need that. And if you're getting into sepsis or septic shock, good luck about trying to bring the person back if you don't have the right antibiotic for giving those things. So so there's other ways, less that require less techniques and less material to administer fluids in somebody. And even that, now the literature is like, should we fluid resuscitation, especially in trauma? There's this concept called permissive hypotension, but the name keeps changing, but mostly that's the one you can see and stuff. And they're even thinking like, maybe we shouldn't be giving fluids to those people. Maybe it should be even blood. So that's another one. So if you have someone dehydrated, sure, you could administer probably fluid by the mouth or intrarectal or something like this. But in for example, if it would be a bad trauma or something like that, in the army, I believe they use on the battlefield. They use what they call walking blood banks. So that means that they have all your they connect somebody to another person, kind of, and they administer blood from another person if you have the right blood type. So that would be probably better alternative than carrying your own stuff with you, especially in a situation where resources limited. And if you don't have, like, there's some situations, for example, in trauma, if you don't have a surgeon, all the cares that we do, like a lot of time when I'm in a helicopter or all the care we do is to maintain it so that the person can go to the OR or the ICU or something like this. So we try to keep them so that they can be brought somewhere, and that's the care that you can give. Well, if you don't have the care that follows it because the system has collapsed, there's nothing you can do. Even if you try the best you can and you intubate and you give like 20 units of blood to this person, what he needs is surgery. And if you're gonna start doing surgery in your living room, good luck. I mean, at one point there's a limitation of what we can do from the knowledge that we have, and we have to accept that, because refusing to accept this and thinking that we can save everybody just because everybody needs a shot is not, I think, from my opinion, is not the proper way of setting that way, because you're setting yourself for failure, because it won't be possible. And so, I mean, there was people that died in the 1950s, or even now in the third world countries, that we could save if they would be living. For example, if you take someone from Africa, they die of stuff that we treat every day here in a big urban center and don't make a big deal of it. They get admitted for 3 days, and then they get discharged, and over there they die of that stuff. I mean, one of the greatest cause of death in children's in the third world countries, diarrhea. Well, we can treat this over here, but over there, it's a big deal because they don't have the resource to administer most of the stuff that we have over here. So unfortunately, those situations will bring problems that we won't be able to